Hello, welcome to another episode of Perfectly Twisted. I'm Nicole and this is Dave Palais with me.
What a morning.
What a morning. What a morning. My tooth fell apart and Dave can't get any of the controls working here in our little box.
No, we're all set. Nicole, I think you jinxed me the other day, by the way. I was very upset with you. And because I think this was your doing, is the other day I was cutting the grass. I'm on the lawnmower and I have my earpods in all the time, which you told me, don't ever go with the earpods. You're going to have problems with the AirPods.
It's like brain cancer, that's all. But yeah.
Well, I ran over him with the lawnmower, $239 down the drain. And I'll be honest with you, the first thing I went through my mind was effing Nicole. God dang it. She manifested this.
Well, okay, you're going to like this story. That was me, Dave. That was me working my magic through manifestation. I bought Keegan a pair for Christmas.
Okay.
Because I know she's not going to be that kid that has them in all the time, but she does need them for working out. Like, it just is a thing. They have to do mile runs. And I was like, oh my gosh, don't be that parent that is like, preaching all the time. And she took them snowboarding the other day, and I did this sarcastic, don't lose one. Like, kind of hoping she lost them. You know what I mean? Like, they fall out and you snowboard right over them.
Yes.
This happens all the time. So yeah, that's me working my magic. You gotta stay away from that wireless devices in your head.
That's very, very, very frustrated. But we're all good. I gotta say, I'm gonna have to go back to him. And it just that's the way I am. I got to.
Even though the universe just you self-destructed your own pair.
Yeah.
You're gonna go back. You're gonna spend that money and do it again. Okay.
I got to try cutting an entire baseball field with nothing in your ears to listen to. It's frustrating.
Dave, you can use wired. And guess what? When they fall, they don't go anywhere because they're attached to you. They don't just fall and bounce and get driven over by a lawnmower.
Something bad's
gonna happen. They stay with you because they have a wire.
That wire is going to drag my face right into the blade. I know it. Something bad's going to happen.
Just like you're going to get sucked into an escalator.
Yes, with my shoelace. Yes.
Yeah. These things don't really happen, Dave. Well, I wish you would rethink it, but it's your pocket and your brain, not mine.
That's it.
Yeah. So today we have an amazing guest. I'm super excited to have her because, as you know, I have hormone estrogen positive cancer, and we're having a lot more conversations about menopause, perimenopause, and how to deal with it. And women are really sort of embracing each other and having these open conversations now. But what is harder to find is women who have had cancer doing any kind of hormone replacement therapy. So I'm on a number of estrogen blockers. So they're depleting my body of my hormones because my cancer was hormone receptor positive. And they just kind of leave you out there with no life vest. I was, medically induced into it and thrown into the deep end. And they just they leave you there to drown. But we have doctors that are, really kind of pulling back the blanket on that and talking about what we can do and, debunking these ideas that women have to stay away from hormone replacement therapy. And it's a very important conversation. So we have Dr. Laila Agrawal, who's an oncologist.
Hi, nice to be here.
So lovely. And thank you so much for coming on and sharing your wisdom. Can you just explain the difference between when it's dangerous and when it's acceptable and the myths behind not being able to use any kind of estrogen at all after cancer?
Yeah, sure. So first of all, it's important to understand that there are so many different kinds of cancer, and some of them are considered to be hormone sensitive cancers. Like, for example, certain types of breast cancer that have estrogen receptor positive and progesterone receptor positive are considered hormone sensitive cancers. And for people who have those types of cancers, a significant part of their treatment may involve hormone lowering or hormone blocking treatments like tamoxifen or aromatase inhibitors, or sometimes medicines called ovarian suppression, or even surgeries to remove the ovaries that would then cause ovarian suppression. But there's many other types of cancers that are not hormone sensitive cancers, different kinds of cancers, and other types of breast cancer, like, for example, triple negative breast cancer. So I think that's the first thing to realize, is that not all cancer is the same and not all breast cancer is the same.
Well, yes, that's right. But we really get into this theory that women should stay away from any kind of hormone replacement at all, right? So you're hearing women who don't even have or haven't had a diagnosis thinking that maybe doing hormone replacement therapy might bring cancer. And we're just hearing so many things, and a lot of women are suffering, and a lot of women are going without treatment and going without any kind of relief. Myself, for instance, I had estrogen positive cancer, and they're just depleting it out of my body. And I have to take it, I have to advocate for myself and find doctors like yourself who are having the conversations of, you don't have to suffer. Like there are things you can do and that are acceptable. And we get so scared, and it is a scary thing, right? And so can you talk to us a little bit about when it's okay and when it isn't okay? Like, is there a crossover? And when it's not okay, why?
Yeah. So when people like you are on these medicines that are lowering or blocking hormones, it can cause side effects that we call menopausal symptoms. So there's a long, constellation of different things people could experience, but some of the top ones are going to be hot flashes, night sweats, brain fog, achy joints or muscles, or pain, stiffness, bone density loss, mood changes in weight or metabolism. And then one thing that I focus on a lot, which I really think is very taboo almost, and a conversation that many people may not have had with their medical teams, is it has major impacts on somebody's sexual health or sexuality also. And this is really, a really prevalent issue, and one that unfortunately I think doesn't get addressed nearly enough. And I think there's a lot of reasons why people may not be bringing it up. Their doctors may not be asking about it. There's a lot of sort of taboo and sometimes even awkwardness around that topic, especially when things are changing. And so I will say that, I'm a medical oncologist. I specialize in the treatment of breast cancer. And, through treating so many of my patients and hearing just how significant they experience changes in their sexual health, I really wanted to not only do better for my own patients, but also be able to educate on what are these sexual health changes and what can we do about it. So, many of these are actually related to changes in hormones. So when hormones decrease, what people can experience is vaginal dryness, decreased lubrication, changes in desire, and often pain with intercourse as well. And so, when we're thinking about all these different menopausal symptoms, we often talk about the hot flashes or the bone pain or things like that. But I really felt that too often the major impacts on somebody's sexual health or sexuality sort of get swept under the rug a little bit.
Absolutely. And I think that maybe it's not the easiest topic to bring up as a female, right? Like, you're maybe embarrassed, you're maybe, it's not something you want to share. And, and I get it. I get that, these are hard conversations to have, but they need to be had. And, estrogen affects your vagina, it affects your face, it affects your mood. And we shouldn't just let these things, we shouldn't just live with it, because there are things we can do. And can you talk to us about the different kinds of estrogen that we can take? And I mean, from female to female, like you can put the vaginal estrogen on your face, correct? Like you can use all of them together.
So I will say that's probably not a completely standard thing to do. So you're going to get different, comments from different people about it. But I will talk about the vaginal estrogen. So, you mentioned the vaginal dryness and what kind of estrogen can be used. And I think it's a big myth out there that just because somebody has had breast cancer, they cannot have any form of estrogen. And so what we really feel very comfortable with is use of what's called a low dose vaginal estrogen in people with breast cancer, people who haven't had breast cancer, in terms of treating this vaginal dryness. So vaginal estrogen comes in different formulations. So there can be a cream, so a estrogen cream. It can come in a type of a suppository that is made in a really low dose, and in an insert. And then there's other types of hormones called DHEA or progesterone that are not estrogen, but are, other hormones that can be converted into estrogen in the tissue and provide that relief. And the major difference between a low dose vaginal estrogen and what's called a systemic estrogen for your whole entire body is that the vaginal estrogen at a low dose is intended to work on that tissue, on the vulva, on the vagina. It's not meant to be absorbed into the body and have effects on the whole entire body. And that's different than other types of hormones that are supposed to be systemically absorbed and, have impacts on menopausal symptoms overall. So that's a big distinction between low dose vaginal estrogens and other hormones that are intended to work locally versus full body systemic hormones.
Yeah, that's very interesting. And what do you say to women who, like myself, with my first oncologist, just shuts you down right away and says, no, you can't have any of that? What do you say to women that take that and believe like that's it, and they're scared to go against anything, their doctor is saying? They get in the system and they follow the protocols and they just stay there and they're left to suffer. So what are questions they can ask? And if they're being shut down, what do you suggest they do?
Yeah, so that's a really tricky one. I think that the understanding about use of vaginal estrogen in breast cancer survivors, including those with hormone receptor positive on tamoxifen or aromatase inhibitors, it's really evolved a lot, even over the past 3-4 years. So if this is a question that somebody has asked in the past, it's always worth bringing it back up again. And one sort of tip that I have is anticipating a clinic visit, or if an appointment is coming up, you can send a message through the medical record system saying, hey, I'm having these issues and I want to talk about it at the visit. Because that helps, number one, just that concern about bringing it up. At least it's already been put out there. The team is going to be prepared to answer the questions. So that's one thing that's kind of been helpful for some people. And then another thing is to ask, multiple people on your team. So if you've asked the medical oncologist, but you also have a gynecologist or a primary care doctor or a breast surgeon, just to kind of understand what the options are for everybody's individual case. So, I think that what I've even observed just from talking to many different medical professionals over the years is that comfort level with vaginal estrogen is very different now than it was previously in the past. And part of it is because new information and new data has come out that is extremely reassuring. So we still don't have, these big randomized trials, which are considered the gold standard, but we do have now really large retrospective studies, meaning looking back in time, saying, okay, we have this group of patients, and it's a really large number of patients. And the ones who used vaginal estrogen, did they have a higher risk of recurrence, or did they have a difference in survival? And so now we have several of these studies that show, hey, overall, there was no difference in recurrence, and there's no worsening of survival if people are using vaginal estrogen. So these really add to our understanding in terms of, is it safe? Is it not safe? What is the risk? But at the end of the day, in my opinion, I don't think this should be a no, you can't have it. This is more a shared decision, meaning we may not know everything about the topic, or everything may not be known. There's not research on every single situation, but this is what is known. This is what is not known. This is your situation. These are the options. These are what we can do to proceed. And then sort of laying it all on the table and having what's called a shared decision, then we can offer these options.
And that's just so important. And, the other thing is women need to open the dialogue with their team, because not all doctors will offer it.
Mm-hmm.
So it's something that you have to, you need to bring it up, and you need to say it. And I know that a lot of women are uncomfortable doing that.
Yes. And, I really believe it should be the doctor's office and the medical team being the one to say, these medicines that you're on, they can change things about your sexual health. Have you had any dryness? Do you have any pain? Has your desire changed? Does it bother you? Or even if you're not sexually active, have you noticed, irritation when you pee, or urgency, or, other issues? So it really, I believe, should be the medical team bringing up these questions, but we know that that's just not the reality currently. So I think it is important that if somebody is out there and they're experiencing changes and they, don't know who to talk to about it, that yes, you can bring it up to your oncology team or your primary care or your gynecologist. The other problem that we see a lot, unfortunately, is that sometimes people get bounced back and forth a lot. Like they may bring something up to their oncology doctor who says, well, maybe you need to talk to your gynecologist about it. And then the gynecologist says, oh, well, you've had breast cancer, so your oncologist has to sign off on this. So that's a little tricky, because I hate to see people bounce back and forth like that. But just in terms of if somebody is not getting the answers they need, then yes, absolutely. You can ask multiple different, people on your team, specialists. If you feel uncomfortable bringing it up with the doctor, you can bring it up with, so oftentimes there's a nurse on the team or a nurse practitioner or a PA, that, someone might feel more comfortable starting the topic. So I would say whoever on your team that you feel comfortable with, you can start the conversation there. And then even if they don't know the answer, it's possible that they can connect with somebody who does. Like there might be a sexual health program or other resource that they can direct people to.
Yes. And you bring up a really important point, because we do get bounced as patients. We do get bounced around, and it's like, no, you have to ask your oncologist. And then and months can go, and weeks can go in between these visits.
Mm-hmm.
And meanwhile, as a patient, you're just suffering. And each time you go, you're told, go back to the other one. You have to ask that one. And it can be very confusing and overwhelming. And so I think that that's a really important point that you bring up, and then the other thing we can do as patients is we get on the internet and go down rabbit holes of, all kinds of misinformation. So,
yeah,
it's, there's just so much information out there, and, it's hard to find the right way. Tell me something that is like the biggest myth of, because we get scared. So I have hormone positive cancer. Now I'm thinking about putting estrogen back into my body, and I'm freaked out because I'm doing everything I can to deplete my body of it. And if it reoccurs, am I going to sit there and say, oh my God, it's because I use the estrogen, vaginal cream? Let's talk a little bit about that and the myths behind that.
Mm-hmm. Yeah. So I think, one myth behind developing cancer is when I see patients and, we're talking about a new diagnosis and it's hormone receptor positive, I think many people feel like they had the wrong amount of estrogen in their body. Like somehow their body was producing too much estrogen, or something wasn't right, and that's what led to it. But the reality is that hormone receptor positive cancer is just the most common type of breast cancer. So if someone develops that type of breast cancer, it's not because there was something, wrong about their body. And I think that's a big myth that I see. And that's almost like a sense of relief when we talk about it and we say, no, this is just the common type of breast cancer. There was nothing that an individual did that would have caused this or resulted in this. And I think similarly with the low dose vaginal estrogen, I think it's just really important. We always talk about pros and cons, risks and benefits. I mean, we talk about this all day long, and it's a matter of balancing those things and also perception of risk and how that feels. And I think that one problem is that sexual symptoms in women have been consistently undervalued. So if somebody's having even sexual pain, dryness, discomfort, hurts when you wear certain clothes or do certain activities, that symptom, I think, has been undervalued. If a woman's pain is not considered that important sometimes. So, when we just say, it's important that you have comfort, that this symptom is not out of control, that you're not having pain with intercourse, those are all important things for quality of life. So, when you're trying to balance these pros and cons, I think it's really important to say how key it is that someone can have sex without pain or, treat those symptoms.
Yes. Yes. And I think, I have to say, I feel like a lot of women are still a little bit hesitant to bring it up and to talk about it. And I feel like maybe there's a little bit of a stigma on it, or they feel shame or embarrassment or any of these things. But women really need to speak up about it. They really do. They really need to say, hey, this, because it's kind of an easy fix, isn't it? Like, tell us if you're having that and you're having pain, when you use the restroom or when you're having sex with your partner, isn't it as easy as, like you said, a cream, a gel, an insert?
So there's lots of options. And there's even options that don't have any hormones in them at all that help the symptom of dryness. And these are called vaginal and vulvar moisturizers. And so even if somebody is, wanting to avoid using a low dose vaginal hormone, there's still options. It's not something that needs to be just, you don't just say there's nothing we can do about it. And so nowadays there's a lot of different products on the market that are called vulvovaginal moisturizers. And some of the brands that I like to recommend to my patients have a hyaluronic acid added into the vaginal vulvar moisturizer. And those can really help with the dryness. So, I tell people that they can use them, 3 to 5 times a week or even every night. It's just another step in the skincare routine at bedtime. So even for people who feel hesitant about using a hormone, and really a lot of our guidelines suggest start with a non-hormonal product. And if that doesn't give sufficient relief, then move up to a low dose vaginal hormone. So these are over the counter. They do help with dryness. They don't do all the things that vaginal hormones can do in terms of affecting the tissue and the thickness and the lubrication and all of that, but they do help with the dryness. So I think that's just step one. So just this feeling that, oh gosh, maybe there's nothing that can be done. Or if somebody feels like, I don't want to take a vaginal hormone, there are still really useful tools that are out there. And then the other thing are, lubricants. So as a medical oncologist, I never thought I would be talking about lubricants this much since I started my, sexual health clinic and practice and all that. But it is so important to have a good lubricant. And many of the ones that are just widely available really do not have great ingredients in it and are probably not the best to use. So especially if somebody's having a lot of dryness and let's say they're using a moisturizer regularly, sometimes I suggest a silicone-based lubricant for intercourse because that is more slippery, longer lasting compared to a water-based lubricant. So I think really kind of understanding these are non-hormonal things that are out there that are over the counter that anybody has access to. Regular use of a moisturizer and then having a really good lubricant as well. And then talking about the vaginal estrogens.
Well, that's really important because I talk a lot about using beauty products and, eliminating the toxins, and people don't realize how it can affect your hormones when you're using the wrong products and when they don't have clean ingredients. So if we're going to put some kind of moisturizer on a very dry area and it's going to be absorbed, and we have to realize that also all products are not created equal when it comes to that as well. So do you have some favorites?
The ones I love to recommend, one of them, the brand is called Good Clean Love, and they make different products, including a moisturizer with hyaluronic acid. And then another one I like to recommend is called Reverie, which is a insert. So it is inserted into the vagina, and then we'll release the moisturizer there. And for the lubricants, the silicone-based lubricant, one I often recommend is called Uber Lube. So these are products that are out there, and I agree. I mean, you do have to be very picky about the ingredients.
Yes. It's something that kind of falls by the wayside a lot of times. And I sit there, and it's crazy because I'll be in like a CVS or a Target or something, and I see, a parent buying something for their teen, and I know that it's a bad product. And I'm like, bite your tongue, Nicole, keep it to yourself.
You want to speak up and tell them, no, don't do that.
Don't put that on your child. I have my children hyper aware, and my teenage daughter luckily loves the Yuka app. I don't know if you use that, and she scans everything. Yeah, and so she'll talk. You pick up something, and she'll tell you what the rating is. Like, she already knows. She's scanned everything. It's hilarious. So things like that are really useful, but I think that makes a huge difference, because what people don't realize is when you look at all the products lined up in the store, there could be one that's amazing placed directly next to one that is toxic.
Mm-hmm.
And they're all at the same price point. They all have cute packaging. So you would think that they're all similar, but they are not.
Mm-hmm. Yeah, you do have to be real picky about that. That's true.
Yes. Oh my gosh. And I mean, and I really want to encourage women too. Like, so a lot of women will come and listen to podcasts like this, or go online and listen to like your posts on Instagram, because they are shy, or scared to bring this topic up in their doctor's office. What advice do you have to women who are in their doctor's office looking at a man who has no idea, can't relate to what she's talking about at all, but you need to get your point across? Are there any like how do you start that conversation? Do you have any tips on that?
Yeah, I mean, I think that there's a couple tips. So number one, if somebody has a partner, a supportive partner, it's, I think, very helpful to have somebody in the room with you, that if you feel nervous about bringing something up, then you've got your support person. They might even be the one who can bring up the question too and start that conversation. Another one is, and a lot of my patients do this, and I really love it, is they'll write down a list of questions. And when they come in, they say, I have these questions that I want to go over. And sometimes we even just start with their questions first. So if you write it down, that might be a little easier. You say, I wrote down these questions, and then you can just kind of read it out rather than having to try to like bring it up and all of that. And then the other thing is, a sexual symptom is a medical symptom, just like anything else, and it is deserving of medical care. And so I know there's a lot of, hesitancy and taboo on both sides, but truly this is a medical condition that is equally deserving of attention, just like anything else. So, some things one could say is, I've noticed some changes. I'm having vaginal dryness and pain. What can I do about this? So just sort of stating what your symptom is, how is it affecting you, and then asking about the options. And, if you've heard about a product, you can always bring it in or ask about it and say, can I use this product? Is this a healthy product for me to use? And if they say, oh, I don't know, then you can always ask, is there somebody I can be referred to? Is there a sexual health program? Is there a clinic? Is there a person who would have more expertise in this who could talk to me about it? So those are just some kind of simple tips on how to bring up that conversation when it feels hard. And then again, I have heard from many patients that if they're a woman and their doctor's a man, that sometimes that adds like another layer of, oh my gosh, I don't want to talk about it with this person. And so that's when you can bring up, if the medical assistant or nurse practitioner is someone you feel more comfortable with, to open the conversation there.
Yes. You know what? I love your idea of writing it down, because also you could read it and then, or you could hand it to them and have them read it. I am somebody who's not shy, and I ask all the questions, and I probably make my doctor uncomfortable sometimes, but but not everybody is like that. And, it's important. And I've had a doctor, we won't say any names. And I went for a consult for a hysterectomy, which is, this is a next step of also depleting the body. And I asked him what any side effects could be. And he looked at me and with a straight face told me, "What do you mean? Like or they're not working for you now anyways. There won't be no change." I was like, well, you're removing a portion of myself. Of course, there's going to be some change. And I'm new to this. Like, before treatment, I might have been perimenopausal, but I wasn't in menopause yet. I was regular with my cycle. And, you get thrown into this so quickly, and it all happens so fast. So I was doing chemotherapy and having hot flashes and night sweats and all of the things all at the same time, right? And you just are like, I don't know if this is the menopause. I don't know if this is the effects from the chemo. Like, you just don't know, and you're just dealing with all the symptoms. So it can get very confusing like that too. So to be able to write it down and say, I'm experiencing this, because we also can forget. Right? You have so many things that hurt. You wake up and your hands are stiff, your knees are stiff. There's just so many things that sometimes we forget, and we move on with our day, and that symptom goes away, and it leaves our mind. So I think writing them down, that's such amazing advice, and writing them down as we feel them and as they're happening, to bring them up when you're with your doctor.
Yeah. I mean, there's so much that you go over in that visit. I mean, so many different aspects of what people experience when they're in cancer survivorship. And sometimes the sexual concern just sort of falls all the way to the bottom of the list and just never gets brought up, even if it's significant. So, I think thank you so much, Nicole, for talking about this, because I think just to say, this is important, this is a real thing, and there is treatment for it. And if we bring it up, we can maybe make some improvements. And the other thing, you kind of mentioned your experience with the talking about a hysterectomy. So the other thing I want to mention is that one of the symptoms that I see a lot is pain with intercourse or pain with penetration. And it's not always due just to vaginal dryness or changes in the tissue, because there can actually also be other things at play, like pelvic floor dysfunction. So actually the muscles around the pelvic area, they can, they're supposed to work together in a coordinated way, but oftentimes when there's a multitude of changes in the pelvic area, stress, many different potential reasons feed into this. But I see this a lot in cancer survivors. Their pelvic floor muscles can work in a way that's not coordinated, and that results in pain. So even if they're using vaginal estrogen, even if they're using the moisturizers and they don't feel dryness, they can still have this symptom of pain. And so for that, I often refer people to a pelvic floor physical therapist. And this can really work wonders for this particular symptom. Sometimes they do exercises with patients. Other times they use something called vaginal dilators, where somebody will on their own use these cylinders that are sort of start small and then get larger in size, and they can work to address the symptom of pain. So not all pain is due to dryness, and there's other causes and other treatments for pelvic floor symptoms.
Yeah, that's important that you bring that up, because that can also happen to women who haven't had cancer. It's and if you can't afford to see a specialist like that, you can look it up online. I know that there's a lot of videos and a lot of blogs that talk about how to deal with that, and it can be quite simple, right? Yeah.
Right. Yeah. So I've certainly seen many people who had a significant amount of pain that really limited their ability to have sex, and then going through pelvic floor therapy and treatment and, doing these exercises at home, were able to really get better, and it made a huge difference. And so when they came back and said, "Oh, I can have sex without any pain," that's like really a wonderful thing to celebrate.
I mean, that's a huge thing. Ladies,
really is.
let's have good sex.
Yes, for sure.
You are allowed. You deserve good sex after everything we've just been through in this roller coaster ride.
Absolutely.
Yeah, don't let it fall by the wayside. Tell everybody where they can find you and all your amazing videos that you post.
So I'm on Instagram at Dr. Laila Agrawal.
Yeah, check her out. Amazing information. And yeah, let's not be afraid to talk about it.
Absolutely.
Thank you so much for doing what you do, because these conversations are so important, and I'm learning day by day, and I know everybody else is too. And just when you have the credentials you have, and you devote your life to this and you speak on it, it just is such a wonderful thing. So thank you so much.
Thank you so much for having me on. I really appreciate it.
Talk to you later.
That's very nice. For very great guest. You always get fantastic guests. Always informative stuff. That's fantastic. That it's your journey has opened the door for so many different things to talk about. I always say you do a great service for people who have been going through the terrible journey that you've been on.
Well, there's just so many things, right? Like,
Right.
It's just so many things, and we experience so many random weird things, and not everybody has the same thing, and a lot of us do have the same, and nobody talks about it, or they don't realize it was associated with the cancer and the treatment, or they don't realize it's associated with the drugs that we are on. Because it is crazy to me how so many people are given limited information when they're given these prescriptions and they go through these procedures. There's not necessarily this talk about like what can happen and what are the side effects and the long-term side effects. So unless you are like myself and you're like on the internet and asking all the questions and just nonstop about it, you could just not even realize. So there are easy fixes. And yeah, I mean, after cancer, the last thing you should do is have terrible sex. Good God almighty. Yeah.
No, you're right. I could say that about a bunch of things. After a bad Halloween, last thing you need is terrible sex. Yes, nobody wants terrible sex.
Nobody wants terrible, painful sex. Good God.
That's true. That's true.
It is. So, yeah. Thanks for listening to us, Dave. And
I know. I'll be honest with you. I'm glad I pulled myself out of the square on that one.
I knew it. I knew.
I was just thinking I figured that the audience, they're sitting there listening to you, and if I was in the square, people are like, "What is the reaction from this guy?"
What's
everything
I've got to say about vaginal dryness.
Yeah, everything I've heard before, but at the same time, it's like the people I think would be staring at me going, all right, let's see what his expression is. Yes. No, I'm glad I pulled myself out of the square.
Well, here's the thing. I hope all of this weird conversation helps you relate to your wife better.
Of course. Yeah. Absolutely.
That's it. So, yeah. We're shaping you. All right. Well, thanks for listening to us, and we will catch you next week.